Welcome to this explainer on lithium carbonate. Now, if you're studying nursing, gearing up for the NCLEX, or already working out there on the floor, you know that psychopharmacology is, well, it's pretty complex. Today, we're zeroing in on a medication that is universally recognized as the delicate, yet absolutely life-saving gold standard of bipolar disorder treatment. We're going to break down exactly how this drug works, why it demands such precise monitoring, and the critical interventions you absolutely need to know to keep your patients safe. Let's get right into it.
Here is our clinical roadmap for today. We'll be covering 1. The gold standard of therapy. 2. Targeting therapeutic levels. 3. Managing side effects. 4. Recognizing toxicity. 5. Critical interventions. And finally, 6. Contraindications and labs.
All right, Section 1, the gold standard, lithium carbonate.
Let's dive into why this decades-old medication is still sitting at the absolute top of bipolar treatment protocols today. Lithium carbonate is a mood stabilizer, and it's primarily used for treating acute mania and preventing those future mood episodes in bipolar disorder. But here's what makes it really unique. Unlike a lot of other psych meds, lithium is not metabolized by the liver. Instead, it is eliminated almost entirely by the kidneys. This is a huge deal because it makes it a totally viable, safe option for patients who have hepatic impairment or liver disease. It literally just bypasses the liver entirely. And that brings us to one of its greatest clinical advantages. If you're taking notes for the NCLEX right now, you definitely want to highlight this. Lithium is the only mood stabilizer that is consistently shown to reduce suicide risk. I mean, think about that. For patients with bipolar disorder who experience suicidal thoughts or have previous attempts, this specific characteristic is absolutely life-saving. It's not just smoothing out their mood, it is actively protecting their life in a way that other medications just haven't proven to do.
Moving on to Section 2. Targeting therapeutic levels. A narrow margin of safety.
Because, look, for all of those incredible life-saving benefits, lithium comes with a catch. It has a very narrow therapeutic index. The margin for error between a dose that heals and a dose that harms is remarkably small. When we're treating an acute manic episode, our target blood level is between 0.8 and 1.2 milliequivalents per liter. But once the patient stabilizes and we shift them into long-term maintenance, that goal drops just a bit, down to 0.6 to 1.0. Now, to make sure these numbers are accurate, timing is literally everything. You have to check blood levels exactly 12 hours after their last dose. And if you change the dosage, you've got to monitor those levels every 2 to 3 days until things stabilize again. But here is the absolute critical warning threshold you have to memorize. A blood level of 1.5 or higher, that is toxic. If you see this number pop up on a lab report, it demands immediate clinical assessment. Because that therapeutic index is just so narrow, a patient can slip from perfectly fine maintenance into dangerous toxicity really fast. Which brings us to Section 3, managing side effects. Expected versus toxic. As patients start taking lithium, their bodies obviously have to adjust, and they are going to experience some expected side effects. We need to be able to distinguish these from actual toxicity. The most common ones you'll see are gastrointestinal issues, think nausea, vomiting, and diarrhea. You'll also frequently see fine hand tremors. Now, notice I said fine tremor there. That's a super important clinical distinction for later. Patients also regularly report increased thirst, polyuria, which is peeing a lot more often, as well as fatigue and some mild weight gain. But the good news, a lot of these GI symptoms are temporary. They usually clear up as the body gets used to the therapy. So how do we manage these? Well, it relies heavily on simple, solid patient education. To help with the stomach irritation, just tell your patients to take their lithium with food. Easy enough, right? But even more crucially, they absolutely must drink plenty of fluids and maintain a consistent sodium intake. Why? Because if they get dehydrated, their blood becomes more concentrated, and that can cause those lithium levels to dangerously spike.
Okay, Section 4, recognizing lithium toxicity, a medical emergency. We just went over the expected side effects, right? But remember, since lithium is cleared by the kidneys, if it's not being excreted properly, it just sits there and accumulates. And that leads to progressive, really dangerous toxicity. It builds up in stages. At mild toxicity, so a level between 1.5 and 2.0, those expected GI symptoms get a lot worse. And that fine tremor we talked about, it suddenly becomes a coarse tremor. The patient might seem confused, they'll have slurred speech, muscle weakness, and excessive sweating. Now, if levels hit that moderate stage, between 2.0 and 2.5, we start seeing blurred vision, tinnitus or ringing in the ears, severe tremors, ataxia, significant hypotension, and even seizures. And finally, if it crosses above 2.5, you are in a life-threatening medical emergency. We're talking profound neurological depression, cardiac arrhythmias, coma, and severe respiratory complications. At this severe stage, the patient will likely need emergency hemodialysis just to scrub the drug out of their system.
Let's look at Section 5, Critical Nursing Interventions, Early Recognition.
So what exactly do you do when you spot these warning signs? As a healthcare professional at the bedside, recognizing toxicity early is your job, and you have to take immediate action. Here is your life-saving algorithm. Step 1. Hold the medication immediately. Absolutely do not give another dose. Step 2. Notify the healthcare provider right away. And Step 3. Assess the patient's neurological status, check their hydration and vitals, and immediately draw blood for a lithium level. If it's a severe case, be ready to administer IV fluids or get them prepped for hemodialysis.
The whole key to this is really understanding the physiology between sodium, fluid, and the kidneys. You see, the kidneys process lithium and sodium in a very similar way. So, if a patient's sodium intake drops suddenly, the kidneys essentially panic. They start holding on to sodium to compensate, and inadvertently, they reabsorb lithium right along with it. This instantly shoots their toxicity risk through the roof. Because of this, unless it's contraindicated for some other reason, you have to encourage them to drink 1.5 to 3 liters of fluid every single day, and make sure that salt intake stays nice and steady.
All right, our final section, Section 6, Contraindications and Lab Monitoring, Systemic Effects.
Since lithium relies entirely on the kidneys to clear out of the body, certain medications and conditions can dangerously jam up that process. Common over-the-counter NSAIDs like ibuprofen and naproxen, thiazide diuretics, and blood pressure medications like ACE inhibitors and ARBs, all of these reduce lithium clearance, pushing blood levels higher. We also have to avoid dehydration from things like intense exercise, extreme heat, or fasting. Plus, lithium needs to be used super cautiously in anyone who already has renal impairment. And please note this critical warning. Lithium is generally completely avoided during the first trimester of pregnancy, simply because there's a significant risk of fetal cardiac abnormalities.
Because it has such wide-ranging systemic effects, long-term monitoring for these patients is pretty intense. You have to routinely check renal function, so your creatinine and estimated GFR. You also need to keep a close eye on thyroid function, specifically TSH and free T4 every 6 months, because being on lithium long-term carries a major risk of inducing hypothyroidism. On top of that, we need periodic electrolyte panels, complete blood counts, pregnancy tests when applicable, and baseline EKGs, especially if you're working with older adults or patients who have underlying heart disease.
All right, I want to leave you with one final clinical scenario to really test your understanding. Think about this. How could a simple, everyday case of the stomach flu suddenly turn a perfectly stable maintenance dose into a full-blown medical emergency? Well, think about that massive fluid and sodium loss from the vomiting and diarrhea. Think about how those panicked kidneys are going to respond by desperately reabsorbing sodium and pulling all that toxic lithium right back in with it. That razor-thin clinical balance is exactly why your vigilant monitoring is the ultimate key to your patient's survival. Thank you so much for joining me on this explainer, and keep learning.